Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and today we are going into our second snippet for 2026. So, Maddie, last time we discussed about anticonvulsants and gabapentin. So, changing the tack today a little bit to antibiotics. Can you please describe the pharmacology of meropenem under subsequent headings? Class and mechanism of action, spectrum of activity, indications for use, and pharmacokinetic and dosing consideration in critically ill patients.
Sure. So meropenem we use quite commonly within the ICU, so it's important to know about this drug. In terms of the class and mechanism of action, meropenem is a carbapenem, and it works by binding to penicillin binding proteins, especially proteins 2 and 3. And this stops the transpeptidation process, which inhibits bacterial cell wall synthesis, and this causes cell lysis for the bacteria. From a spectrum of activity, it has a very broad spectrum of activity against many anaerobic gram-positive and gram-negative bacteria, including ESBL organisms and CRE. But it's important to know it's not active against many resistant gram-positive organisms such as MRSA and most staph epi. So you'll see we often use Mero with Vanc in patients with profound septic shock who we're not sure about the etiology and has a high risk of MROs because meropenem won't cover those gram-positive organisms. It's also not active against Stenotrophomonas multifilia, Ephesium, and atypical organisms. So you'll see in patients with things like that, pneumonias who are at risk of atypical organism, they'll still be on something like azithromycin or doxycycline. From an indications for use perspective, just starting off very broad, it's used for multi-resistant gram-negative infections, either suspected or proven. And then we can think about specific infections it's used for and empirical therapy that it's used for. So for specific infections, it's the first-line treatment for melioidosis and for multi-resistant enterobacterial infection. And for drug-resistant typhoid or paratyphoid infections, if IV therapy is required. And then from an empirical therapy point of view, for patients who have necrotizing skin and soft tissue infections and people with generally lots of sepsis or infections of patients who have known colonization or recent infection with multi-drug resistant gram-negative bacteria or who are at high risk of multi-drug resistant gram-negative bacteremia. So that's for patients with febrile neutropenia, hospital-acquired sepsis or septic shock, meningitis. And then also for those who polymicrobial sepsis and complicated intra-abdominal infections or high severity community-acquired pneumonia in tropical regions of Australia. And this is because of the risk for melioidosis. Then there's also those patients with severe hypersensitivity reactions to penicillin with any of these conditions or failure of first-line therapy in critically ill, hospitalised or immunosuppressed patients. So you might have seen it on your ward rounds if patients been on tazocin for a few days and we've got no growth and no exact pathogen identified, but they're deteriorating and have profound septic shock. A lot of people would then escalate to meropenem. From a pharmacokinetic and dosing considerations in critically ill patients, so we can think about this in terms of the pharmacokinetic properties, so distribution, metabolism, and elimination. Absorption is not an issue because meropenem is just given IV. So from a distribution perspective, we know that meropenem has minimal protein binding at about 2% and a small volume of distribution. But in the critically ill, this volume of distribution increases in the critically ill, and they might need a higher dosing or initial loading or dose or a higher dose, or they might need doses administered by a prolonged or continuous infusion. And sorry, I don't mean small volume of distribution. They have a larger volume of distribution. So they have approximately 21 litres or 0.3 to 0.4 litres a kilo for patients who are not critically unwell. This is why you might also see patients in ICU. It's often recommended in the critically ill to give them like a prolonged infusion rather than like a more of a bolus dosing. From a metabolism point of view, meropenem is metabolized by hydrolysis into an inactive metabolite and has minimal hepatic metabolism. So in terms of the impact on the critically ill, you don't need to dose adjust it for patients with liver impairment. And then from an elimination point of view, meropenem undergoes predominant renal clearance by both filtration and tubular secretion, with about 70% excreted unchanged in the urine, and quite a short half-life of just 1 hour in the healthy population. But we know that in critically ill patients, this half-life is increased in patients with renal impairment, and the plasma clearance correlates with creatinine clearance. So we do need to dose adjust and reduce the dose in those with renal impairment. We also know that it's cleared by dialysis and that the clearance is approximately 4 times higher with dialysis compared to those who are anuric. So if patient is on intermittent dialysis, we give them the doses after the session. It still requires dose reduction for intermittent hemodialysis and peritoneal dialysis, but doesn't require as much or sometimes even no dose reduction for those on CRRT. And we know that patients on CRRT are actually at risk of being underdosed. And then finally, critically ill patients sometimes have a very high cardiac output state. So especially those young patients with severe sepsis or patients with burns. And this can cause an increased GFR and augmented renal clearance. So these patients are less likely to achieve percentage of time over the MIC, which is important kill characteristics for meropenem. So we often need to increase the dose in these patients and because they've had a risk of underdosing. And similarly, we often use prolonged infusions in these ICU patients to maximize the percentage of time under MIC for patients being treated with meropenem.
Thanks, Mandy. That's a good point. Obviously, now there's a trend towards asking the questions with a bit more specific sub-questions. So you have a clear direction about how to write an answer for these questions. And I think this question can be asked in various different ways. The area under the curve, MIC, that concept about the whole dose response thing with antibiotics can be again explored in a more from a pharmacokinetic point of view with regards to antibiotics and classify antibiotics according to each phenomena.
Other thing is, so when looking through them and the examiner feedback and stuff, we can also see that a lot of them, they do get repeated in subsequent years for those that haven't, had great responses. So it is worthwhile having a look at that and seeing, what's been asked before and what people haven't really performed that well in.
Absolutely. And I always tell my candidates, like in any of primary exam, the 70% questions are going to be repeat. So even if you prepare all the past papers from last 5 to 7 years, there is no way you will not get 70% marks. So I think it's important that even if you stick to the past papers and then revise those questions repeatedly, I think the chance of success is going to go exponentially high. So yes, it's important to cover the whole syllabus, but you need to be a bit more smart and wise about your preparation. So make sure that you do cover all the past questions from the papers in depth. Thanks, Madi. That's the end of our today's snippet. We'll be back in month's time with another snippet. Till then, goodbye and have a nice time.
Thanks for listening and see you next time.